All right, welcome in everyone. So glad to have everyone here. We're just going to go ahead and make a start this morning. I can, hang on one second here. Okay. All right, so good morning and welcome. Joining us from wherever you are today. We're happy to see you in our virtual education community. This is the Great Lakes ROTA-RC presentation on parent-child interaction therapy in the context of recovery. Today's session is being hosted by the Great Lakes ROTA-RC regional partner, UW-Madison Division of Extension. So we want to thank them for sponsoring our speaker today. I'll be your host this morning. My name is Amanda Cura, and I'm ROTA-RC's Regional Project Manager. Before we get into our presentation, we have a few quick housekeeping items to go over. I'm going to start by just making mention of our funder and our funding activities. So if we could just roll to the next slide real quick. And it's just to kind of mention that we are, in fact, a Substance Abuse and Mental Health Services Administration, or SAMHSA, funded project. We are Region 5, which covers Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin, but we welcome just everybody in today. So it doesn't matter where you're coming from, we're happy to have you. And that kind of indicates a little bit of what we do, but let me expand on that a little farther. So we do provide virtual or on-demand education in those Region 5 states, but we also do evidence-based resources and research, as well as technical outreach, specifically to professionals working in and with rural communities. We're going to take a minute now and we're just going to pop up a demographic poll. We appreciate you taking just a minute to help us with that demographic poll. Like I said, we are funding supported through SAMHSA, so that demographic poll helps us communicate which communities that we are reaching out to and which communities we need to try and extend a little bit further outreach. So thank you for doing that. Once you're done, just remember to hit submit, and then we'll know when everybody's had a chance to do that. And a reminder that there is an option to hit prefer not to respond if you prefer that selection.
I just have to say I love the demographic poll where you have the question between 0 to 4 years old. You gotta love extension.
Right? I mean, sometimes you feel like that, right? Is it our chronological age, or mental age, or social age? All right. Let's give it one more second. Start to, looks like everybody's wrapping her up there. Welcome into everybody who's joining us. Glad to have you. Happy Thursday. Weekend's almost here. It is still summer.
I'm going to end poll since it seems like it's slowed down.
All right. Awesome sauce. It does not want to come off my screen. I'll deal with it in a minute. All right. All right. So we're going to move on to our next screen and start heading into our session for today. So as we do that, let's prepare ourselves to listen and engage in the session content. Before we begin, we want to just take a moment to promote the use of affirming person-first language when discussing behavioral health disorders. As we create an environment of learning together, we want to feel welcoming and safe for everyone. So we want to just kind of create that environment together. As we manage that space, we want it to feel non-stigmatizing, recovery-orientated in our language. So that kind of helps reduce that negative bias and promotes engagement for everybody. As always, we invite you to learn about successful prevention, treatment, and recovery from whatever space you're joining us from today. And we welcome you formally into the Great Lakes ROTA-RC community of learning. We're going to move now into introducing you to today's presenter. Dr. Dimitri Topitzes is an LCSW and serving social work professor and department chair at UW-Milwaukee. He is the Director of Clinical Services for the Institute for Child and Family Wellbeing at Milwaukee, Wisconsin. As a researcher, he partners with community-based agencies to implement and test innovative trauma-responsive programming. As an instructor, he founded and directed the Trauma-Informed Care graduate program at UW-Milwaukee, and he teaches courses within it such as trauma counseling and mindfulness and community building. And with that, I turn you over to our presenter for the remainder of the session.
Fantastic. Thank you very much, Amanda. And welcome, everybody. Delighted to be here on this Thursday morning. As you say, happily, inspiringly, still in summer, Amanda. 2 more weeks left, at least on my end. So today what I'd like to do in our brief time together is to talk a little bit about connections between trauma, addiction, and parenting using some data that we have collected here at University of Wisconsin-Milwaukee. With the help of Wisconsin-based home visiting programs. And I'd also like to talk a little bit about how a particular parent management intervention by the name of parent-child interaction therapy can promote or support recovery on the part of parents of young children. My understanding is that as we move along, feel free to share your questions in the chat, and then we'll have a robust question and answer period after our formal 1-hour presentation period. Before I start, I want to give a shout out to, I want to acknowledge colleagues of mine here in Milwaukee. First and foremost, my friend and coworker at the University of Wisconsin-Milwaukee, Josh Mursky, with whom I've partnered on a number of data-based empirical projects, some of which I'll show today, results of which I'll show today. Also want to acknowledge partners here in the Milwaukee area at Children's Wisconsin, Gabe, Luke, and Leah, as well as my PCIT international global trainers that have introduced me to this particular intervention, parent-child interaction therapy, and that's Christy Warner-Metzger and Cheryl McNeil, both clinical or counseling psychologists. Also want to acknowledge funders over the course of time that we've done this work here in Milwaukee, and that includes the Substance Abuse and Mental Health Services Administration and the Wisconsin Department of Children and Families. Okay, so let's dive right in. I want to first and foremost develop a working definition, a shared working definition of the term trauma, and then identify the effects of trauma, including substance use and including its effects on parenting, and then how parent-child interaction therapy can potentially address all of these issues: trauma, mental health, behavioral health, and promote ultimately recovery. Okay, so much of what I'm going to share right now is going to be somewhat review in nature, but I think it's helpful, again, just to develop a shared working definition of the term trauma. This kind of forms the basis of our work today. So when we say someone has experienced trauma, we always mean, of course, that they've encountered 2 separate phenomena. Number one, an exposure to some kind of event or circumstance, and some kind of consequence, sequelae, or symptom profile that emerges in the aftermath of that exposure. So we want to understand both what do we mean by exposures and what kinds of after effects can ensue in the aftermath of trauma exposure. Okay, so according to the official mental health definition of trauma exposure, a potential traumatic event is one that involves actual or threat of death, serious physical injury, or sexual violence. And we have that experience in any one of 4 different modalities. It happens directly to me, I witness it, I learn about it happening to a loved one, or I hear about it happening to someone with whom I'm working in a helping profession, so in a client, for instance. So any one of those 4 modalities, any one of these 3 major categories of events, and there are a number of hallmark examples listed here on the slide. This emerges from the Diagnostic Statistical Manual, edition 5, in the PTSD symptom criteria, criterion A. Now, many people in the trauma studies world would argue that this is not an exhaustive definition of a potential traumatic event, just the exposure sort of component of the phenomenon. It's not exhaustive for at least 3 reasons. Number one, it doesn't include non-physical types of experiences like emotional abuse, emotionally coercive relationships, etc. Secondly, it doesn't necessarily take into account not just acute events that are traumatic and overwhelming, but also ultimately conditions or circumstances that tend to be traumatic and overwhelming. We have some really good data from the University of Wisconsin Madison, Seth Pollack, experimental psychologist, developmental psychologist at UW-Madison, the Weissman Center, who shows that exposure to ongoing poverty as a child can mimic the very effects of exposure to child abuse and neglect. So we want to think about circumstances like poverty, like exposure to racism stress, like exposure to ongoing homelessness, ongoing detrimental, stressful circumstances that might constitute a trauma over time, particularly for young people, but also for adults. And then the third limitation of this mental health definition is that it doesn't necessarily take into account subjectivity or individual variation. What you all might experience as stressful, I might experience as traumatically stressful, and we want to honor that within our definition. So many people in the trauma studies world prefer this particular definition of trauma and trauma exposure, which reads as follows. Trauma is an event, series of events, or set of circumstances. So right away, it expands this notion of trauma just being an acute event. An event, series of event, or set of circumstances that are experienced by an individual as. In that language, experienced by an individual as ultimately helps us take into account subjectivity, individual variation, etc. As what? As physically or emotionally harmful, life-threatening, injurious, etc. So not just physically problematic, but also potentially emotionally problematic. And these are circumstances or events, however, that are not just everyday events, that aren't just stressful in nature that ultimately I can overcome either with my own internal resources or external resources or both. These are experiences that ultimately will have lasting effects in any one of or combination of a number of domains. And those are included there. So this is the working definition of trauma that many people in the trauma studies world rely on. There are others that are related to this. One, for instance, that was developed by a theorist out of University of Southern California by the name of John Briere. But this one tends to be more popular. That one is similar to this, but this one tends to be more popular, and it expands our notion of trauma while at the same time reminding us that it's not just any old experience. It's one that's going to have long-term effects on any number of domains. If you have any comments or questions, don't hesitate to throw those in the chat. Okay. So what we saw previously was a definition of individual trauma. We also want to give a nod to Maria Yellowhorse Braveheart out of the University of New Mexico, or New Mexico State. I get them confused, forgive me. She's in New Mexico, and she has done groundbreaking work on the topic of historical trauma. She argues that historical trauma is the cumulative emotional and psychological wounding over the lifespan and across generations. That's what's key, across generations, that ultimately emanates from mass trauma group experience. Genocide, relocation, terrorism, etc., that is perpetrated on any one particular group, race, etc. The effects of these events or experiences are transmitted intergenerationally, if not the experiences themselves. And they're often perpetuated by ongoing policy and practices. And how these two are connected, which is often helpful to highlight, is that those groups that have been exposed to historical trauma, collective trauma, individuals within those groups are also at higher risk for exposure to individual trauma. But we also want to honor the fact that trauma is relatively ubiquitous. It spans many different boundaries, racial boundaries, economic boundaries, etc. So it tends to be a relatively universal phenomenon, while at the same time, it also tends to be, at least traumatic experiences tend to be concentrated amongst certain groups that are of low income status, or as I mentioned earlier, have been subject to trauma historically. Okay. Again, any comments or questions, don't hesitate to share them in the chat. This is, again, relatively common information, but I just wanted to share it again as a kind of as a shared framework from which now we can we can move on. So what I'd like to next do is to share information from the Families and Children Thriving Study, an investigation that my colleague Josh Mirsky heads. I'm a part of this as a co-evaluator. And what we've done in this particular study is to track over 1,400 low-income families served by Family Foundation's home visiting program here in Wisconsin. These are programs that are ultimately funded by the federal government, and they serve low-income families. They serve families that have newborns, either mothers that are about to give birth or have just given birth, and they provide case management and referral supports for these families so that they can enhance the probability that the children will experience positive outcomes over time. Typically, these services are available for up to 3 years postpartum. So in this particular study, mothers completed surveys at multiple time points, and we tracked child, parent, and family outcomes, not just at one point in time. It's a longitudinal study, but over a series of years and months, months and years, I should say. And we focused in this particular presentation, I want to focus on the experience of trauma as defined by that second, or sort of as marked by that second definition that I shared. Okay, here are some data points to better understand the prevalence of adverse childhood experiences. It's a synonym for trauma if we're using that second definition. And these are, I think, helpful to view when thinking about the prevalence of trauma amongst low-income at-risk families, or mothers in particular. 26.4% of the women that we surveyed, and remember this is over 1,400 Wisconsin women in both urban and rural settings, and they were of diverse race and ethnicity, and primarily of young ages, 20s and 30s. 26.4% said that they experienced sexual abuse as children, so 1 in 4. Over 40% said that they lived with someone who had mental illness when they were children, and over 40% said that they lived with their caregivers, or that their parents were separated or divorced. And when we look at this as in a cumulative fashion, we see that 85% of the mothers that we surveyed reported at least one childhood trauma, whereas over 2/3 reported 2 or more childhood traumas. These are really high numbers of trauma adversity in childhood. When we look at ACE scores, or cumulative ACE type, we see that those who reported 4 or more ACE type exposures, in other words, exposure to sexual abuse and physical abuse, and maybe parental separation, incarceration of a parent, 4 or more ACE types, 43% of our sample, the home visiting sample, endorsed 4 or more types of ACE exposure, as opposed to 14% in the population at large in Wisconsin, underscoring the earlier point that I made, that while trauma is somewhat ubiquitous, it is really concentrated among certain communities, particularly low-income communities or communities of color. We didn't stop there, though. In our survey questionnaire, we also asked about exposure to what we refer to as adverse grown-up experiences, or ages, because obviously adversity and trauma doesn't end when someone turns the magical age of 18. And we wanted to better understand what were the types of adversities that these women were exposed to. These are parents, mothers of newborns. What types of adversities did they experience as adults? So we asked about, for instance, physical abuse by a partner, emotional abuse by a partner, alcohol or drug misuse by a partner, alcohol misuse or drug use by a partner, mental health problems of a partner, for instance, that may have had something like depression, anxiety, etc. The experience of incarceration or jail on the part of a partner. And also we asked about other experiences that may have taken place outside the context of a partnership: forced sexual activity, crime victimization, homelessness, chronic poverty, and discrimination. And I don't need to run through the numbers. You can see them. They're astronomically high from our vantage point. Nearly 50% said that they experienced physical abuse within their romantic partnerships. Nearly 2/3 said that they experienced emotional abuse in that context, almost a half. said that their partners at some point experienced jail or incarceration, prison, in other words. 1/3 experienced homelessness as an adult, and 85% experienced 1 or more ages, whereas 70% experienced 2 or more ages. And what's really fascinating about these figures is that the average age of our respondents was 27, meaning that these figures will never go down. They can only go up. So these are astronomical figures that might become even more inflated over time, sadly speaking. So this is a somewhat bleak picture, quite frankly. We asked the question of ourselves, so we did some data analysis, and we asked the question, well, how are adverse childhood experiences related to adverse grown-up experiences? So we looked at the number of ACEs that people may have experienced, number of type of ACEs, anywhere from 0 to 4 or more. And then what percentage of those respondents who experienced that particular number of ACEs, what percentage of them experience 4 or more adverse grown-up experiences? And you can see there's this common ladder-like graded relationship between ACE exposure and some kind of unwanted outcome like adverse grown-up experiences. And this reinforces what is often referred to as the cycle of victimization. Maybe not the best terminology, but simply meaning that if I've experienced a trauma or some kind of node of victimization as a child, that increases my possibility or probability of experiencing victimization as an adult. Maybe something that is isomorphic to what I experienced as a child. So if I experienced physical abuse as a child, perhaps I'll experience physical assault as an adult, but it doesn't necessarily have to be isomorphic or sort of the same type of event. So early exposure to trauma predicts later exposure to trauma. Again, somewhat of a bleak picture, but reinforcing the point that this is a really significant topic, issue, experience that we want to pay attention to in a number of fields, including in the behavioral health field and the mental health fields. And why the mental and behavioral health fields? Well, we also asked ourselves the question, or asked the data the question, I should say better. We asked the data the question, well, are childhood traumas also related to not just adult experiences of adversity, but also adult experiences of mental health related challenges, like, for instance, depression. This is postpartum depression, the Edinburgh scale. We found that, again, the same ladder-like dose-response graded relationship between childhood exposures to trauma and this somewhat unwanted, obviously unwanted outcome of postnatal depression. So if I had 0 ACEs as a child, if I reported 0 ACEs as a child, then my probability of experiencing or reporting depression as a mother postnatal, 4.7%, as opposed to 22.6% if I had 5 or more ACEs. We also see the same type of relationship, and this is key. I'm not showing data here. We haven't finalized these data, but we see similar types of relationships between ACEs and behavioral health outcomes like alcohol use, drug use, early initiation. You name your drug-related or behavioral health-related outcomes, smoking initiation, current smoking use, et cetera. We see that same ladder-like dose-response relationship between adverse childhood experiences and behavioral health outcomes, just like with mental health outcomes. And there are a number of different luminaries in this field who have made the assertion based on the data that they've collected, Dr. Vincent Felitti being primary amongst them, that the relationship between compulsive use, according to him, this is a quote, appears to be one, or the compulsive user appears to be one who, or the one who's engaged in compulsive use, I would prefer to say, appears to be someone who, not having other resolutions available, seeks relief by using materials with known psychoactive benefit, accepting the long-term consequences. So in other words, many people in the field argue that we really want to think of it, not for every case, but for many cases, What is underlying the use of substances? What sorts of experiences and what sorts of emotional and physical discomfort might be underlying the use of substances? And how can we address both at the same time? And this is why integrative treatment tends to be on the ascent, according to my read anyway, certainly tends to be more tolerable, if not more effective, than sequential treatment. Just a plug for integrative treatment, and we could certainly talk about that after the formal presentation. Gabor Mate, a addictionologist, a physician who's studied and treated addiction in British Columbia and has written a great deal about it, a relatively popular figure these days in the trauma studies world, argues that we want to ask ourselves the question, not just why the addiction, but also why the underlying pain. Last slide of data that I want to share is the following. Okay, time 10:26, doing okay. In our FACT study, the Families and Children Thriving study, we collected data not just on the mothers, but we also collected data on the mothers' children, and data that helped us understand what were the children's sort of scores on externalizing problems as reported by the mother. These are mother reports, excuse me, and dysregulation problems. And what we found, interestingly enough, again, is this same dose-response ladder-like graded relationship between exposure to different or accumulated ACE types over time on the part of the mother, and the children's probability of having greater externalizing or dysregulation problems. So what does that mean? We don't know exactly, but it suggests that perhaps ACEs are affecting exposure to adult adversities, mental health, behavioral health, and potentially even parenting. And maybe even the adult's ACEs somehow are increasing the probability that the child is being exposed to adversity. So that's a bit of a leap, but we're arguing or asserting or hypothesizing that this slide is suggesting to us that ACEs could affect mother's parenting, I should say, mother's parenting. So early trauma could affect parenting, which ultimately could maybe even introduce the new generation to a new experience of adversity. So what we could be seeing is the intergenerational transmission of adversity or even trauma in this slide. But what we do know we're seeing is that ACEs within or across or among mothers increases the probability that their children are going to be maybe lagging a little bit behind on behavioral markers of development. Again, please don't hesitate to ask any questions in the chat as we're rolling along. Okay. So we consider all these data and these outcomes. And we also take into account anecdotes and reports from our community partners who are working with caregivers who are presenting with mental or behavioral health related challenges, caregivers of young children in particular, and come to the conclusion that mothers who are in recovery or who are flirting with recovery, considering recovery, certainly could potentially use some support in enhancing their caregiving skills with their young children. I'm not making that assumption for all mothers in recovery or entering recovery, but we are making that hypothesis for at least some mothers, given the data that we've seen, including this particular slide. And this is where it's where kind of parent-child interaction therapy comes into the equation, into the conversation. So parent-child interaction therapy, we would argue, could very well be a really helpful adjunct, supplement, augmentation to a caregiver's recovery plan. So particularly a caregiver of young children. Parent-child interaction therapy is tailored for children ages 2 to 7. And if a caregiver has been experiencing substance use related challenges, and that has potentially, they think that has affected their caregiving, and maybe data suggests that it's affected their caregiving, then parent-child interaction therapy might be a helpful corrective input. It might offer helpful corrective inputs in order for that parent to develop some new specialized skills and enhance their child's development over time. We're doing really well with time, so I'm going to take a break, Amanda, if that's okay with you, and take a look at the chat. And I see that Jamie has posed a question. If mothers with high ACEs have children with emotional and behavioral regulation problem, then down the line, the mother enters recovery and healing. What is the option to help the child also regain that recovery and healing? Exactly. The hope is that down the line isn't too far down the line. The hope is that that recovery is as early as possible. And if it's within that those early preschool and elementary school ages, school ages, say 2 to 7, parent-child interaction therapy can be a really helpful, as I mentioned, a really helpful service. You can even use PCIT modified for ages 1 to 2 and a modified PCI version for like ages 7 to 8. But regardless if it's PCIT or not, what I would argue is that however old the child is, whatever the intervention might be, I think it's best done dyadically or within a family systems context, so there can be corrective experiences there. So for instance, if the child is older than, say, in teens, then I would recommend something like functional family therapy or trauma-focused cognitive behavioral therapy, which is family systems and orientation. It requires individual healing or a focus on individual healing, individual skill development, individual kind of trauma narrative potentially. But ultimately, it also brings in the family system or the caregiver in such a way that it can help heal that relationship, transform that relationship. And I think that that's a critical component of the type of services or the type of transformation, the type of focus that the questioner is asking about. So family systems or dyadic related work is what I would argue for, and parent-child interaction therapy I think is a good example of that for young children. I hope that addressed the question at least to some extent. I would also assert, before I move on real quickly, I would also assert that that type of work can not only help the child, but can really help the caregiver as well. Have a sense of resolution, self-forgiveness, etc. Okay, I'm going to move on, and then we can come back to the helpful chat dialogue or questions. Okay, so what is parent-child interaction therapy? Let's dive a little bit into this. This is a parent training intervention that I've been well trained in and have been training others in for the last 10 years or so. And like other parent training interventions, it tends to be the most successful type of or family of approaches to address child mental and behavioral related challenges. What's really cool is because it's parent mediated, it involves the parent, it also tends to, as I mentioned earlier, enhance parent sort of cognitions and parent behaviors and practices. So it tends to be really helpful both for the children and for the adults. And what's one real critical hallmark of these types of interventions, and something that I like a ton, is that it is engaging, it's active, it's experiential. It requires a lot of investment, emotional, energetic investment on the part of the clinician and on the part of the caregiver both. And also, I think because of that, it tends to be the most, or this family of interventions tend to be the most efficacious amongst interventions that are targeting child mental and behavioral or mental health related challenges. Common elements of PTIs include the following, as mentioned earlier. They're really targeted interventions. They're not comprehensive. They're not broad-based comprehensive interventions. There's plenty of space and room for that. It's great. But these are targeted interventions that are focused primarily on the parent-child interaction and ultimately on child development. While they're focused on child development and resolution of child-related challenges, they're parent-mediated, as I mentioned earlier. So it's not the therapist or the clinician that's ultimately the agent of change. Of course, they're initiating or promoting or facilitating, supporting change. It's ultimately the caregiver that is the agent of change, which makes ultimately the change then, I think, more sustainable, more generalizable. It's skills focused. It's not insight oriented. These are skills focused interventions, and they focus primarily on providing what was referred to as consistent contingencies and positive parent-child interactions. And consistent contingencies just simply means that the caregiver is providing an environment, both physical, but more importantly, behavioral and psychological, an environment that is predictable and is going to reinforce the types of experiences that are pro-social and growth promoting for the child. Okay. PCIT, let's dive. Well, how are we doing for time? Okay, can take, so we're going to cover, oh, this looks like to be a, all right, well, I'm going to pass on the chat for now. We'll come back to it. So let's dive a little bit more deeply into PCIT. So ultimately, PCIT attempts to promote two factors. The first is bonding, positive emotions, and a sense of connection and attachment. And I'm using the term attachment non-technically currently, but a sense of connection and attachment and affection between the caregiver, the parent, and the child. So to increase positive attention, decrease negative attention. But secondarily, it also attempts to promote parent discipline or parent management skills. So consistent limit setting, and doing so by helping a parent being really consistent. And by consistent, we mean every time a child requires either support or boundaries, that the caregiver is actually introducing support or bringing on support or introducing limits or boundaries. So consistency, predictability. They're doing this in a way that is relatively familiar to the child. So when they're using their positive discipline skills, they're using language and behavior that signals to the child that we're in discipline land, we're in limit setting land. And so it's not it's certainly not punitive. It's certainly not abusive. It tends to be signaled to the child in very calm, kind, and rational terms. And it's predictable because the same language and same cues are given to the child every time, and that the parent is committed to following through with their discipline in order to help the child regulate and in order to help the child recognize that the parent has authority here in a very kind of reassuring type of way. Okay. So what are the core features and active ingredients of parent-child interaction therapy? The key active ingredient is coaching. So the clinician or interventionist coaches the caregiver or the parent as the parent is interacting with their young child. And they coach them either physically in the same room, if it's a very young child and the child can tolerate that, it's not a problem, or they use a two-way mirror, a bug-in-the-ear device. There are various ways to do it, or they go online and remotely engage with the family more and more. That's happening within homework, remotely connecting with the caregiver via a phone and an online connection, or a laptop connection, an internet connection. But they're coaching the parent to help the parent enhance their child bonding skills and enhance their positive discipline skills. And that in vivo active coaching is the primary ingredient of change, the primary agent of change in this intervention. And ultimately what the coaching does is to restructure interactions. Oftentimes with caregivers who come to PCIT based on challenges that their children present with, or challenges that they present with, or challenges that the dyad presents with, kind of synergistically, ultimately what this intervention helps to do is it helps to enhance positive attention when in fact it's indicated, decrease negative attention, and then bring on, introduce positive discipline where it has been lacking. Oftentimes when we're working with families, they're giving the children attention at the wrong times, and they're disciplining the children in very inconsistent and sometimes punitive if not, unfortunately, abusive ways. So really to kind of reverse engineer the whole process. So the parent is giving attention at times when the children are interacting in ways that are really positive for that child's development. And we're teaching them discipline skills that are really helpful for the child. Help the child ultimately internalize positive discipline and self-regulatory skills. We also have the parents do home practice. So not only are they engaging either 60 to 90 minutes a week in a in-clinic or in-home PCIT session, but they're also practicing during what's called special play in order to generalize their skills beyond the session and also to overlearn those skills so that they can sustain them beyond the end of the service episode. The intervention is assessment driven. It's not time limited. It tends to be mastery based. So parents and children graduate when they've mastered certain skills, which is a key feature in my estimation of the effects of the intervention. And it tends to be empirically supported, and we can talk a little bit about that later. Okay, it's been integrated into many systems, including child welfare, with positive effects. There are lots of studies in child welfare, including several that my colleagues and I have conducted to show that it's efficacious within that context. As I mentioned, it's tailored for young children. It addresses multiple problems. It's been shown to be effective with multiple problems, including child abuse. In other words, children who present with child abuse histories. This intervention has reduced recidivism amongst those children, amongst those families. It reduces child externalizing behavior problems like aggression, inattention, noncompliance. And it also reduces children's internalizing behavior problems. We think that the child-directed component helps with internalizing problems, the bonding with the parent, whereas the parent-directed component, teaching parents to discipline their children in positive ways, helpful ways, that helps with child externalizing problems. But it's also helped with parenting stress. It also helps with parenting skills and parenting satisfaction, something that can be really, I think, relevant for parents potentially in recovery. The typical time period, or the typical sort of time limit, is 12 to 14 weeks, but for families with more sort of complex presentations, it can take upwards to 28, 30 weeks. There really is no time limit. It's a mastery-based intervention at best. Okay, as I alluded, how are we doing on time? Okay, good. As I alluded, there are two phases to the intervention. There's the child-directed phase, oftentimes referred to as CDI, and then the parent-directed phase. The child-directed phase is really meant to enhance parent-child bonding, affection, connection, relational quality, etc. In this particular phase, the child takes the lead in kind of a play therapy context, and the parent is there just to kind of provide consistent attention and support, affection, etc. The clinician supports the parent in doing this type of work, and sadly, this isn't an interaction pattern that we all sort of learn intuitively or easily or naturally. I didn't know this interactive pattern before I learned PCIT, so I was delighted to learn it. But I learned it by virtue of firstly being taught it through instruction, then the intervention would model it for me. Then I would role play it and they would sort of give me positive feedback or corrective feedback. And then I would engage with a young person, with a child, and they would coach me as I did so. These are the sort of the clinical modalities for learning these specialized caregiving skills. And ultimately, what we're teaching parents in this context is to engage with children in sort of a play therapeutic manner, strengthen their attachment to the child. There's some budding evidence that this does enhance attachment from a technical standpoint, but I want to be very modest and humble about that, and I don't want to make that assertion quite yet. So when I use the term attachment here, I'm using it in a non-technical way. This is an interest. I'll kind of go down this path just a little bit. What are we teaching the parents in this context? We're teaching them to avoid making any commands to the children, not asking the children any questions. I had a real hard time with that. I'd always ask young children questions, but instead we want them to kind of take the lead in this particular context and avoid any criticisms of the child. And instead, what we are teaching the parents to do is to provide really specific praise for what the child is doing during their play, to reflect utterances that the children share, imitate the child's play in some sort of adult general fashion, in order to give the sense that we're right there with that child. Describe the child's behavior. This is what we're teaching the parents to do, and to do all this with a sense of enthusiasm. Also, if the children engage in behaviors that are unwanted, not dangerous or damaging, but instead just unwanted behaviors, then we teach selective attention, where they ignore that behavior. And then when the child sort of returns to a behavior that tends to be more developmentally facilitative, then we really reinforce that through label praise or positive reinforcement. It's that the intervention is based on attachment principles, but also behavioral principles. And what's fascinating is that these simple exercises, these simple skills, can really strengthen the bond between a parent and a caregiver. These skills aren't meant to be used throughout the course of a day. They're only meant to be used during these sort of special sacred times. We call it special play. And the research suggests, and clinical anecdotes suggest, and parent reports suggest that this can really be helpful in strengthening the parent-child relationship. But that sort of creates the foundation, helps to build the foundation for the next phase, which is parent-directed interaction. And in this particular phase, we're teaching caregivers specialized skills in child management. And ultimately, what we're doing is we are helping them kind of get out of these kinds of coercive processes that parents often get in, where they're reinforcing the wrong things with kids. And then ultimately the kids are engaging in negative behaviors that the parents are reinforcing. We're trying to help them sort of get out of that through consistent contingency management. We're teaching them, first and foremost, kind of these guidelines for effective commands, which I certainly didn't know before I engaged in this intervention, learned this intervention, like using direct commands, specific commands, age-appropriate commands, being really polite and kind when sharing a command, et cetera. But then also teaching them a follow-up procedure if the child doesn't necessarily follow that command. And we can talk a little bit about how people in the trauma studies world might feel a little bit averse to this particular phase, and more specifically, the timeout sequence, or the calm down sequence, as some people like to call it. There's a debate in the trauma world whether or not this is really indicated for trauma affected children. My bias is absolutely, and I can kind of go down that road a little bit more. But let me first describe what is this calm down or timeout sequence if the child is having a hard time regulating and ultimately complying with the caregiver directive. So first and foremost, if the child does comply, a lot of positive reinforcement. If the child doesn't comply, then there's a warning, then there's a use of a timeout chair, and then there's even a use of a backup timeout room where the parent is present, so the child isn't in danger. And then these are used in sequence in a way that ultimately promotes the extinguishing of these kinds of dysregulated behaviors, if you will. Again, when we're teaching parents and coaching parents through this process, we're really helping them maintain a sense of consistency. So if the children are engaging dysregulated or non-compliant behavior, then right away we're asking the parents to engage in a kind, present, direct, rational process. We help them do so in a very non-reactive way, in a kind way, in a present way, and a non-punitive way, where we're just removing positive reinforcement. We're not introducing any kind of punishment. I won't show this unless time permits, and I don't think it will, but there is a really cool local TV news report that shows PCIT in action, including a timeout in action, and that link is here on my slide deck, and so you're welcome to copy and paste that and check that out. We won't have time to view it, but you will have access to this slide deck presentation, so feel free to check that out. It's really illustrative. It's really helpful. I won't review the many randomized controlled trials that have been conducted on PCIT, only to say that it's been shown to be efficacious across various settings, across a number of different communities, and it's been adapted for instance, child welfare, It's been adapted for various communities like Native communities in Oklahoma. It's been adapted and modified for Mexican American communities in Los Angeles. It's been adapted and modified for Black families or Black American families in the Midwest, and again has been shown to be efficacious across these various contexts and communities. And so that's really quite encouraging. And this is the common pattern that we will see within these randomized controlled trials over time through what are called mixed effects models, just an analysis strategy that is used with repeated measures, a repeated measure, say, of an externalizing behavior. A parent will share multiple times their reports of the children's externalizing behavior. And if they're in the PCIT group, what we see is the blue line where the reports of the behavior decline. The negative behaviors are declining. The externalizing behaviors are reducing over time, according to parent report. Whereas for the control group or the waitlist control group, those behaviors aren't necessarily declining, and this tends to be a statistically significant effect, and more importantly, a practically significant effect. Like, it really makes a difference in the children's and the parents' lives. Parents are more or less stressed. They feel more connected to their children. They feel like their family is kind of getting on track, and the children's development is getting more on track as well. Okay. Where are we at for time? Perfect, 10:51. So that sort of concludes the formal component of the presentation. I know I ran through these slides relatively quickly, but let me stop here and turn it over to Amanda, and then we can re-engage in question and answer and dive into more specifics in just a moment.
Excellent. All right, so we're going to just go through a couple of follow-up points. We'll stop the recording and then we'll open it up for question and answer. So we just want to thank you for being part of our virtual learning event today. I want to just share with you a couple of items for follow-up. First of all, like Dimitri said, we will make sure that the recording from today, the slides, and any other, there's a toolkit that we have to follow up with today's presentation that will all be on the Great Lakes website. We'll pop that in the chat here in a minute. Before we do that, if you joined us today because someone shared the link with you, which is perfectly fine, please make sure that you continue to do that. We'd like to get our message across wide to anybody and everybody who's interested. But we just want to make sure that we get your full name and email address so that you can join our newsletter, get information on more events just like this coming up in the future. If you could just please make sure that you send that to our email address. If you pop it in the chat, we might not be able to get to it as quickly and you might miss out on our newsletter, which is coming out later today. So make sure you just email it to our project email address. The next thing that we want to share with you today is the evaluation link. We'll pop that in as well here. Give me 2 seconds. That evaluation link tells us a little bit how you found today's presentation. We want to make sure that we get some feedback on how that went, how you found the event, gives our presenter a little bit of feedback as well. There we go, pop that in. And lets us know how we're doing. What other events you'd like to see, what other needs you have across the region. That really just helps us continue to the best as a project across the region in meeting your needs as professionals regarding substance use disorder and other mental health use disorder needs that you might have. So that's helpful if you can just take a few minutes to do that. The link will also be on the website. So if you're busy and you don't get a chance to do that, or if you know someone else who wants to follow up with today's presentation recordings, please ask them to also follow up with that evaluation, because all of it helps. And then the last thing that we want to share with you today is upcoming events. So next week we have Grief, the Flip Side of the Trauma-Informed Care Coin, will be happening on Wednesday, August 23rd. And then we have a 3-part series that is being hosted by our Great Lakes ROTA-RC partners from Michigan. And they're doing a Reimagining Recovery series. So you don't have to attend all 3 parts. You can attend one of those dates, 2 of those dates, or all 3 dates, whichever you like. But we encourage you to check any and all of those events out. Plus, September actually looks like quite an active month. So if you like those, please go to the website. Please check it out. There's a lot going on to keep you busy this fall. I'm going to go ahead. We're going to stop the recording there, and then we're going to turn it over to Dimitri and all of you to go ahead and ask your questions. And I just want to go back up through the flow of chat here. I did notice, just in terms of follow-up to the chat there, maybe just a potential kind of check-in. I know you mentioned, Dimitri, that PCIT was kind of for 2 to 7-year-old range. It looked like there was a little bit of interest in kind of preteen range. Anything you might recommend as far as supporting those who are wanting to do maybe something around this work with preteen?
Yeah. So as I mentioned earlier, I mean, there are a number of interventions, I think, that involve both the caregiver and the child. And it's, from my vantage point, like these are the most reliably effective interventions when it comes to enhancing the parent-child interaction therapy. I don't know that there's been specific research on the caregivers in recovery, and if this is particularly effective for caregivers in recovery, but I do know that these are from a bonding standpoint, from an improvement of relationship standpoint, these are the best interventions. They include individual components, but they also include conjoint caregiver-child components, and these are the interventions that I would recommend. I think they're the most reliably effective. So I gave a few examples earlier: parent-child. Trauma-focused cognitive behavioral therapy. And it's a really well-known intervention, probably the most empirically validated trauma-based intervention for children, but it's dyadic in nature, which is great. It involves the parent and the caregiver. The child will talk about, for instance, their experience of adversity, and the caregiver is there witnessing, observing, receiving that experience, that narrative. And that can just be incredibly powerful, particularly, I would think, if it involves experiences that the child has endured as a part of the caregiver's using history, perhaps. It can be really, really powerful. Now, it requires, for the caregiver, it requires their own preparation and their own therapeutic service within this context, which is great. There are accommodations for that. There's a parent component of this intervention, which is great. And so it can help the caregiver engage in self-forgiveness, which I think can be just a critical component of not only recovery, but also parent-child interaction and parent-child relationship. So TFCBT or some variant thereof, I think is excellent. I'm trained in TFCBT, so I know it best. I know PCIT and TFCBT and a few other trauma resolution techniques, so I know it best. So I would refer to that, but more generally, I would refer to any intervention that involves the caregiver and the child. Even if the child is an adolescent, we tend to think, well, they're an adolescent, let's just give them their own work, their own intervention, their own treatment. Adolescents need us as much as children, but just in a different way. It's a different kind of, the need looks a little bit different, and from my vantage point. Functional family therapy, FFT, is another evidence-based intervention that could be reviewed or could be explored. Excuse me. So that's what I would share there. Another point I would make, thinking about younger children, I know we're asking about adolescents or 12-year-olds or pre-adolescents, but thinking about younger children, there are some that would argue that, well, aren't expressive therapies really good for younger children? And I totally agree. There are expressive therapies like play therapy really help children unwind and resolve their experience of adversity. Those are really great techniques. They have nice evidence behind them. But what I really think is powerful is when you combine expressive therapies with also family systems work. And PCIT does that a little bit. It's not like the children are necessarily, when they're engaging in play, they're necessarily resolving their traumas. They're really strengthening their relationship with their adults. But there's another therapy that I love. I'll put it in the chat here for younger children that combines expressive therapies with also family systems work or caregiver support, filial therapy, which is done here in Milwaukee at Meta House, a really kind of a beacon of recovery support for women of young children who are in recovery. Meta House, many people I'm sure have heard of it here in Wisconsin, but filial therapy is a real nice therapy for young children who've grown up in a house where maybe where an adult had substance use related challenges. And because it involves the caregiver as well. It's not just expressive therapy, but it's expressive therapy with the caregiver. I love it. I think it's dynamite. So those are the principles I would argue for, and those are a few of the examples of the interventions that I think are really worthy of exploration. And there are more. There are many more, but those are just a few.